we're here. Thank you so much, Belén, for being here. Welcome back to another AJL Symposium here from Vienna, Austria, together with Oftalmo University. We're very happy to be again together working on this incredible symposium. Today, we're going to have great speakers, outstanding KOL, key opinion leader in the cornea and anterior segment field. We're going to start right now with Belén Alfonso. She's from Spain, of course, from Instituto Fernández-Vega, and today she brings a great talk about a new device, Neoring.
Yeah.
It's a new device for cornea. Let's see what she brings for us. Belén, welcome, and thank you so much for being here.
Thank you so much for your kind presentation. And now we are going to start talking about a new pre-descemetic corneal ring called Neoring in deep anterior lamellar keratoplasty for moderate and advanced keratoconus. We are going to present this study that which purpose is to evaluate the morphological and functional results of the implantation of a new PMMA pre-descemetic corneal ring during DALK in patients with keratoconus. This is a prospective study, and with this study we obtain the CE marking. First of all, we must start talking about the astigmatism that we can find in patients with DALK due to keratoconus. This astigmatism could be low, moderate, or high, symmetric or asymmetric, and also with the rule oblique or against the rule. The origin of this astigmatism could be on the donor, on the host, or also on the surgical technique. And also this astigmatism could be stable or progressive during the postoperative period. We also must talk about the complications that we can find in patients with DALK due to keratoconus, and these complications could be the short-term complications, secondary to Descemet's membrane ectasia, like steep keratometry, or central linear or concentric folds, as you can see in this picture. And also could be secondary to the thickness inconsistencies, like anterior or posterior steps, usually on the lower half of the cornea, and ocular surface alterations, and an early astigmatism, against the rule. Also, we must talk about the long-term complications that can be a recurrence of keratoconus in the donor, that we know that it's already described in patients with penetrating and lamellar keratoplasty, and the progression of keratoconus in the host, that we know that are described in penetrating keratoplasty but not yet in lamellar keratoplasties. And also we must remember the metallic crewmates ring that is described in patients with keratoplasty. It was used initially for PK and was implanted at the graft-host interface between the two corneas. The purpose of this metal ring is modulate the healing, but also we know that can reduce the final astigmatism and also the reduced immune reaction. Our group has experience with this metal ring in 5 cases of DALK due to keratoconus. In these cases, the ring was implanted in a pre-descemetic pocket in the host cornea, and we obtained good morphological and functional results with a low astigmatism. The problem here was that the economic cost was high and the aesthetic aspect too obvious, as you can see in these pictures. For this reason, we consider the development of this pre-descemetic corneal ring that has a circular section made of PMMA. It has also a thickness of 0.20 millimeters, and this Neoring is available in 3 diameters, 8, 8.5, and 9 millimeters. The objective of this implant in patients with DALK due to keratoconus are, in the short term, add thickness to the host cornea and obtain low and symmetrical astigmatism below 4 diopters, and also in the long term try to reinforce the host cornea. So, in this prospective study, we included patients with keratoconus with indication of DALK. The best corrected visual acuity before the DALK was equal to or less than 0.5. The mean keratometry was greater than 50 diopters, the mean central pachymetry less than 450 microns, and the axial length greater than 23.5 millimeters. In the sample, we included 10 eyes of 10 patients with a mean age of 36 years old, and the minimum follow-up for all the patients was 24 months. So regarding surgery, as you can see in this video, a conventional trephination of 8.0 millimeters were performed with a manual dissection of the stroma, starting of the edge of the trephination using the angular technique. In these cases, we left a residual bed of 50 or 75 microns measured by ultrasonic pachymetry. As you can see here, we make a peripheral pocket of 8.5 millimeters where we introduce the Neoring. And finally, we place the donor cornea, which will be oversized by 0.25 millimeters. And then we perform the 16 sutures, the stitches. Here we have the surgical images of the first 5 patients in the study, and here those of the last 5. We can see how there were no intraoperative complications in any case and how ring implantation was possible in all patients. Regarding the results obtained, here we can see the first 5 patients operated on 2 years after surgery, and here the last 5 patients. So if we start talking about the complications, we haven't found faults in the cement membrane, anterior or posterior steps, or alterations in the corneal surface. Just in one case, we saw an early astigmatism against the rule. Also about the possibility of a recurrence of keratoconus in the donor cornea or of a progression of keratoconus in the host cornea, we will have to be assessed in a few years. If we talk about the thickness consistencies, as you can see here, the host cornea with the Neoring is always greater than the donor cornea, avoiding the posterior step. In this table, we can see that the thickness of the recipient cornea behind the ring, also the thickness of the host cornea in the area of the ring, and finally the thickness of the donor cornea in front of the ring. So, without the ring, the thickness of the donor cornea would always have been greater than the thickness of the host cornea. For this reason, when we use this new device, this Neoring, no significant previous or subsequent steps have been observed. Regarding the visual acuity and refraction 2 years after surgery, we can see that all patients have a refractive astigmatism less than 3 diopters, which is related to the keratometric cylinder. Also, the corrected distance visual acuity is greater than 0.7 in all cases. And if we analyze the keratometry, the endothelial cell density, and the pachymetry, we can see that are within acceptable limits. So, regarding the evolution of the data, we can highlight that from the start of the suture removal 6 months after surgery, the refractive cylinder is lower than 4 diopters, and the best corrected visual acuity improved during the postoperative period. So, as discussion, it's important to remember that when we analyze the results related to the DAL technique, we observe that they are different depending on the initial pathology of the patients, and also are different depending on the surgical technique, a descemetic or pre-descemetic technique. So there is a mixture of content and concepts that we must take into account when comparing the results. So if we compare our results about the refractive astigmatism and the sphere, you can see that our results are similar than the results of Salotti that use the same surgical technique, a pre-descemetic technique, but they use a more large trephination of 8.5 and 9 millimeters. And that's important because nowadays the options that currently described to prevent complications in patients with gout due to keratoconus refer specifically to the surgical technique, mainly the use of different diameters in the trephination. So, if you use an equal diameter between the donor and the host, it leads to decreased keratometry, but faults of the cement membrane are not avoided. But if we use a large diameter of 8.5 or 9 millimeters, both could be avoided, but the postoperative risks are increased. Also, if we talk about the femtosecond laser, we know that would also allow us to create smoother, more perpendicular edges, but we only can use this kind of technology when we have an early stage of keratoconus. So Neoring as a prevention methods provide us with consistent thicknesses between the donor and the host. It could be an effective long-term booster in the host cornea to prevent the progress of keratoconus. So as conclusions, Neoring in DALK for keratoconus is a recommended procedure with unacceptable modifications of the surgical technique. The thickness inconsistencies are avoided and good morphological and functional results are obtained, being considered an effective and safe technique. But only over the years we will see if in addition it prevents dyscarectasia. Thank you so much.
Thank you so much, Belén. Amazing talk, great presentation. I just want to ask you if you consider for every lamellar anterior transplant this device, and if you advise for all of us cornea surgeons to use the Neoring for all our transplant, because your results are so good.
Of course, we think that we must use this new implant, but not only for patients, for keratoconus patients, even we can use this device in another pathologies, but the main indication in these cases could be this, no? Patients with keratoconus that has a thinner cornea, we can provide this thickness in this part of the...
Excellent, excellent. Well, thank you so much for your time. It was an enormous pleasure to have you here. And well, hope to see you soon here in AJL Symposium next year.
Of course.
Thank you so much. So we had the first presentation, and now we can say the original, or she's the original?
She's the original.
She's the good one.
The good one.
She's the good one. Okay, now the father of Belén, Dr. José Alfonso, he doesn't need any presentation. Thank you so much for being here, doctor. We're going to talk about another incredible device for cornea surgery. It's the ENDO-K Pro, and Dr. José Alfonso will present excellent results, and he will teach us about this procedure and about this device. Thank you so much for being here.
Thank you.
Time is all yours.
To change the presentation, it's possible to change. Change. Lo que debería no es. Good afternoon. Thank you for the company Andres Benati to invite this presentation to do this presentation. And well, we are going to present a new concept of corneal transplantation. We have named it Pseudochamber protected keratoplasty with ENDO-K implant. The Fernández-Vega Institute received an economic contribution for research in relation to the product ENDO-K. Well, ENDO-K is an intracorneal implant developed at the Fernández-Vega Institute in collaboration with the AJL Spanish company, and which is already available on the market. As we can see in the figure, the implant consists of a peripheral ring, a transparent central disc, and 4 spokes. The implant is placed between the host cornea and the donor cornea, as we can see in these images taken with slit lamp and OCT. The surgical step of the PPK with ENDO-K can be summarized as follows. In the host cornea, we perform partial trepanation, lamellar dissection of the stroma up to pre-descemetic level, and a peripheral corneal pocket. After that, we place the ENDO-K on the stromal bed with the peripheral ring inserted in the corneal pocket and fixed by means of a provisional 7-0 silk suture. Finally, we suture a full thickness donor cornea 0.25 greater than the host diameter. The suture of the donor cornea with the usual 10-0 nylon should be performed above the peripheral ring of the ENDO-K. The last step of the surgery is to introduce BSS or viscoelastic in the pseudochamber to separate both corneas. In this video, we can see the surgical technique in a patient operated on 4 years ago. The reason for the transplant was a corneal edema without stromal vascularization. The patient also presented aphakia, anterior and posterior synechia, normal intraocular pressure, and no previous vitrectomy. As we said before, the surgical steps are 4. Lamellar stromal dissection with Meles spatula, dissection of the pre-descemetic pocket, fixation of the ENDO-K with 7-0 silk suture into the pocket in order to facilitate the suture of the transplant, and finally suture the full thickness graft with 16 nylon stitches above the peripheral ring. This is the normal procedure, the normal technique, and you can see the steps is very easy, the normal step of a lamellar keratoplasty. The first stitches of silk is only to maintain the cornea, the donor cornea, without problem with the suture. The second case is a patient with previous retinal surgery and intraocular silicone oil. The characteristics of the patient is no previous graft, corneal edema, posterior synechia, posterior chamber AJL, control intraocular pressure with drops, and retinal surgery with silicone oil, intraocular silicone oil. This is the suture, the provisional suture of the ENDO-K in the pocket, and with a 7-0 silk. This is the usual, usual sutures, only to provisionally fix the ENDO-K, and after the normal suture of the donor cornea. In the postoperative period, we have 2 options. Maintain the receptor stroma bed if we want or need to protect the donor cornea of the intraocular pathology, or remove the receptor stromal bed below the central disc. If we want to improve the patient vision, or in this case, we can use the JAK laser, the femtosecond laser, or the vitrectomy scissor, depending on the thickness of the residual stroma. In this slide, we can see 3 examples of this second option. The next video is the method to removal of the recipient stromal bed. This stromal bed includes deep stroma, the cement membrane, non-functioning endothelium of the host cornea. Can be performed with a femtosecond laser, as we see in this video, or with a vitrectomy scissor. To remove the cut stroma, we enter with a vitrectomy forceps through a 20 gauges limbal incision below the stromal bed. This maneuver can also perform with the JAK laser, with the condition that the thickness of the bed must be less than 75 microns. The indication for the techniques are all those cases considered to have a bad prognosis for a penetrating keratoplasty. Eyes with corneal pathology associated or not associated with complicated intraocular surgery, or cases of trauma, or even previous failed transplant. From August 2018 to the present, we have operated on 71 patients of PPK with ENDO-K. All of them very complicated cases, with various associated pathologies. To classify the surgical indication, we assessed 6 parameters: previous corneal transplant or not, characteristic of the cornea, iris morphology and function, aphakic or pseudophakic eye, intraocular pressure status, and previous retinal or vitreous surgery with or without silicone oil. In this way, we can easily define the profile of each patient. In this case, for example, the indication was justified by corneal neovascularization secondary to complicated surgery, and the patient had undergone vitrectomy with silicone oil. In this other case, however, the corneal edema was secondary to glaucoma surgery with valve implantation. The follow-up of patient is very simple and is based on the control of 4 parameters like the corneal transparency with the slit lamp, the evolution of the pseudochamber with anterior segment OCT, the evolution of the endothelial cells with a specular microscope, and the intraocular pressure with eye care tonometer or digital tonometry. This slide summarizes the results of the technique in the best cases. We will only comment the ENDO-K cases without previous penetrating keratoplasty at its longest follow-up. These cases are the best to start performing the technique. So we see that of the 39 operated eyes, 31 maintain a transparent cornea with an endothelial cell density greater than 500 cells. The rest of the patients have received a new transplant or are pending to perform it or have preferred not to perform more surgeries. In total, more than 90% of the operated cases have been resolved. On the other hand, to resolve 39 cases, we have needed 48 corneas, 1.23 corneas per case, similar ratio as when the first endothelial keratoplasties begin to be performed, for example. In the cases in which endothelial microscopy could be performed without difficulty, that is, without edema, a maximum in endothelial density was observed at the 6th month, and then a slow but progressive decreases over the months, but always maintaining values above 1,000 cells per square millimeter. To date, the main identified cause of endothelial cell loss is peripheral contact of the residual stroma with the donor endothelium. Among the intraoperative advantages of the procedure, we have the most important: to perform a closed chamber surgery, and therefore the possibility to combine another surgeries such as cataract surgery. In this video, for example, we present an ENDO-K combined with lensectomy for advanced cataract. In this case, the cataract was very hard and extracapsular extraction was performed without lens implantation. We can see what is the maneuver to remove the cataract. We use the hook, the iris hook. I perform a scleral incision and also perform the cataract extraction, only the cataract, not implant new lens. This is patient with no prior transplant, corneal thinning secondary to ichthyosis, anterior and posterior synechia. The intraocular pressure was controlled with eye drops and retina without surgery. I am using the same technique. You perform the cataract previous to the implant of the ENDO-K through the residual bed to obtain a very thin residual bed that possibilitate perform the cataract, and after we continue with the transplant in the normal step, with the normal steps, with 16 stitches. You can see the scleral incision and the keratoplasty. Regarding the postoperative advantages, the non-perforation of the corneal brings less risk of immune reaction, intraocular infection, and endothelial damage. On the other hand, it is also possible to perform secondary surgeries to solve problems like intraocular pressure or retinal pathology. And finally, it is possible to perform safely a new transplant without the need to remove the ENDO-K. In relation to intraoperative inconveniences, we cannot highlight any. Lamellar dissection with the classic angular technique could be one, but it is very important not to perforate the host stromal bed. So I don't recommend it, the big bubble technique in these cases. As postoperative inconveniences, we have first the protrusion of the residual stroma between the four spokes of the ENDO-K. In some cases, a peripheral contact between both cornea can occur, causing a failure of the endothelial cells of the donor cornea. To avoid this problem, we have found 4 solutions. The first, to regulate intraocular pressure before or after surgery. The second, to make a hole in the stromal bed with a JAK laser. The third, perform an injection of viscoelastic in the pseudochamber using a 30-gauge needle through the donor cornea just above of the ENDO-K spokes. And finally, advance in the development of ENDO-K and improving surgical technique. The objective of these changes is reduce the space between the spokes of the ENDO-K and then separate both corneas as much as possible. We can see the evolution of this idea in this video. This is a patient with no prior transplant, corneal edema, without new vessels, anterior synechia, pseudophakia, intraocular pressure control with surgery and drops, and no retinal surgery. The most important changes in the techniques is you can see in the slide. The diameter of the host must be today 7.75 millimeter. We use the ENDO-K of 8.5 millimeters. The diameter of the donor 8.25, and so the pocket to put the peripheral ring of the ENDO-K 0.75 millimeter more than host. So 0.5 millimeter bigger the donor of the host, and also use the ENDO-K with 8.5 millimeters. This is our standard procedure today. With these changes, we are avoiding the possibility of contact between the residual bed and the endothelial of the donor. Another postoperative problem is the appearance of a fibrin membrane inside the pseudochamber covering the prosthesis. This membrane is typical when we have new vessels in the host residual bed. To prevent the appearance of fibrin, corticosteroid treatment should be maintained as in conventional transplant. As a last drawback, we have the presence of the residual stromal bed, which logically limits visual acuity depending on its thickness. If the visual prognosis is good, a hole is made in the receptor stroma below the central disc. When the thickness of the residual stroma is between 50 and 75 microns, the JAK laser can be used to make the hole. When the stromal bed is larger than 100 microns, the femtosecond laser or vitrectomy scissor should be used as alternative. Well, in conclusion, we can say that the new ENDO-K intracorneal implant allows a full thickness corneal transplant without the need to perforate the cornea. It is the most important target, not perforate the cornea. It is an effective and safe procedure with multiple advantages, and it can be an alternative to high risk of penetrating keratoplasty. Thank you for your kind attention.
Doctor, thank you so much. Incredible talk. Congratulations for this device, for this develop. And I want to highlight two things. One, we improve the graft survival of the cornea because I saw the results, almost 95% between 6 months and 48 months follow-up. And the other is safety because we work with a closed chamber, and that is so important, right?
I think this is important here. It's the concept, the new concept, not perforate the cornea. When you have a patient that you are thinking that the possibility of endothelial keratoplasty, no, the lamellar keratoplasty, no, also, well, you only have the option to do a penetrating keratoplasty. This is the error, to do a penetrating keratoplasty. It's better to perform a lamellar, not perforating, to use the ENDO-K. This is the message, no? Not perforate the cornea, because in the future
you're going to have a problem. And your conclusion were very, very clear. This is for cornea with poor prognosis.
Yeah.
We have an alternative to improve that prognosis, and I think that is the strong message here.
Yeah. Yes, thank you.
Thank you so much. A pleasure to have you here. Thank you so much.